All right, let's get started with our first panel. It's Are You There, Doctor? It's me, Menopause, Perimenopause, and it's going to be Menopause 101 questions. So let's bring up our first panelist today, Dr. Cheryl Kinney, an OBGYN, Director of the Center for Female Health and Hormone Disorders here in Dallas, Texas, and the 2025 President-elect of the Menopause Society. Hi, good to see you. Good to see you. Next is Robin Noble, who's going to be joining us, an OBGYN with a master's in healthcare delivery science, medical director of Intermed, and serves as a chief medical advisor for Let's Talk Menopause. And Dr. Vanessa Soviero is an OBGYN, the medical director of a multi-physician practice in New York, a Menopause Society certified OBGYN and bilingual practitioner. Good to see you. All right. We have lots of questions, but I think it's always important to start off with the language, right, around menopause, so people understand definitions and maybe just kind of where they are in this whole transition. And I've been traveling quite a bit around the country, and there's still a lot of confusion as to what some of these different stages are and what they mean. So I would love, Dr. Noble, if you can start talking about perimenopause, menopause, and postmenopause, and how those are defined.
Perfect. All right. So happy to do this intro because, Tamsen, as you mentioned, I think the definitions are really important because they're confusing and it adds to the confusion. And, one of our our mission is really to demystify some of these concepts and the whole process for people. And if we can't use the same language, it's really about those definitions so we can all communicate, destigmatize this process. And perimenopause is really the years before the final menstrual period. And this makes it so confusing because some people might have had a hysterectomy. They might have one of these IUDs that doesn't reveal when someone's cycling, when they're bleeding. So it's really semantics, but perimenopause are the years prior to the final menstrual period where some of these cycle changes start occurring and some of the symptoms start occurring. And it includes the year after that final menstrual period. Postmenopause are the years after. And I often have patients ask me, am I through it? Is it over? And I say the menopausal transition is over if they're in postmenopause, but postmenopause lasts for the rest of our lives. So we're not through it, we're in it. So it's understanding peri or the years before. The final menstrual period really defines menopause, but it's a retrospective diagnosis. We can't tell till 12 months have elapsed. Okay, and then postmenopause are all the years following it. And there isn't a finite time of when perimenopause begins. It's when people start noticing changes in their cycles. Sometimes their cycles become closer together. Sometimes they get more precipitous symptoms of premenstrual syndrome, breast tenderness, menstrual migraines. We'll go over symptoms a little bit later, but it's when those symptoms start to become bothersome, you notice them, that qualifies as perimenopause. So it shouldn't be a big mystery. We can use that term. It's those years around it. And I think one other really important factor is if these cycles are changing, it can be a clue because this is really about reproductive aging. So if someone has not finished their family or they want to have a child, we need to be aware that if these changes are happening, we should act on those and counsel people. We will get better in the future with more predictive testing, but right now we don't have a test to tell us when that final menstrual period will be. And it really doesn't matter. That date is not what's important. It's managing the symptoms. A couple terms here, just premature before the age of 40, early from 40 to 45. And we'll go over in the symposium, really why it's important to treat those people who experience an earlier menopause because there's an impact on our cardiovascular system, our bone health, our brain health. Natural menopause is when we go through that naturally, whereas surgical is if someone has their ovaries removed. Medical is often induced for treatment of certain hormone-sensitive cancers. So those both surgical and medical can be more abrupt and more symptomatic for people. It's important in this slide to notice that perimenopause is a time where these hormones really go through these roller coasters. And that's why people have so many symptoms and they can be so variable that they can sometimes report that they really only have like one good week in their cycle. They're either premenstrual, they can have heavy bleeding, and there are times where we need to work up abnormal bleeding. So there are certain times where it's important to know what's kind of a normal transition and when we have to step in. And there's so many treatment options. You can see that we'll go over a little bit more, but that estrogen and progesterone are critical to so many body systems: bone, brain health, cardiovascular system. They're in our eyes, our ears, our joints. So just examples to show you how impactful estrogen and progesterone and those changes can be on our bodies.
Okay, I want to talk about the 2002 study, and Dr. Kinney, I'm going to this. We often talk about that when we talk about hormone therapy. The next panel is going to be all about hormone therapy, so just so you're aware of that. But we want to talk, top level right now to just really understand where we are. The WHI study that's about 2002, how that gave us menopause care for this nurse.
So it was disastrous. But in the 1980s, we gave women hormone therapy, not just to treat their menopause symptoms, but also because we were trained and we had evidence that it helped prevent cardiovascular disease or heart disease. So a group of researchers got together and said, well, hey, if hormone therapy helps prevent cardiovascular disease in these young menopausal patients, maybe it'll do the same thing for older women. So the WHI was really about whether or not hormone therapy could prevent chronic disease, particularly heart disease, in older patients. Well, 5 years plus into the study, some of the scientists involved called a news conference and basically announced to the world that they were stopping the study prematurely because they had found an increased incidence of breast cancer in patients who took hormones, an increased risk of stroke in patients who took hormones, and that it turned out the hormones didn't really help cardiovascular disease according to their findings. So the consequence of this was a dramatic shift in women's thinking and in doctors' thinkings. Women stopped using hormone therapy. Prescriptions in the United States plummeted from, I think it was 90 million to 10 million. Now it's down to 4 million. The doctors of that time basically started telling women it's dangerous to take hormone therapy. And then an entire generation of medical students and residents were trained that hormone therapy was dangerous. And so this left a large proportion of our population at risk for chronic disease. Well, thank goodness there were doctors at the time, and Dr. Malone was one of them, who looked at the data and said, wait a minute, that doesn't look like it's correct. Now, there weren't a lot of people who did that, but there were enough. And then there started to be a groundswell of people who really started to analyze the data. And over the last 20 years, every single one of those findings really has been walked back. So, for instance, we now know that hormone therapy is cardioprotective. You start it early, and for the rest of your life, you will benefit from taking those hormones. Same thing, if you're young and healthy and under the age of 60, when you start hormones, the risk of stroke is almost minuscule. And as far as breast cancer is concerned, and that's what this slide is about, all the groups should have a placebo group, which is the one in pink, that's exactly the same. Those are the women who didn't get any hormones at all. Well, look at that. You can tell with the group in which they concluded that hormones caused breast cancer, that there is something wrong with that placebo group. And again, doctors like Dr. Malone looked at that and saw it at the time. And we also have to keep in perspective, because now we know that other drugs are even more risky than hormone therapy, even if there is an increased risk of breast cancer. How many of you are on a statin? Yeah. So the increased risk of breast cancer with a statin use is twice what it is with estrogen therapy, according to this study. So again, a lot of the dogma that came out of the WHI in 2002 has now been refuted.
So let's go back and talk about perimenopause, because that can be a very interesting time. And I really want Dr. Soviero, to jump in and talk about so many changes that are happening day to day in our lives with our symptoms. We go back and talk about some of the most common symptoms of perimenopause, since we know there's not this official test that okay, we have to look at our symptoms and determine where we are.
Yeah, so perimenopausal symptoms are pretty much the same as menopausal symptoms, except I would argue sometimes even worse. Now, for many women, perimenopausal symptoms can either start a few months to a few years before their last menstrual period, or for some, perimenopausal symptoms can actually start about 10 years before their last menstrual period. And if the average age of menopause is 52, that means if you were going to go into menopause at 52, your perimenopausal symptoms could start at 42. But if you were going to go into menopause at 45, then your symptoms can start in your mid 30s. So it's different for everyone, and no one knows when they're going to go into menopause. So not all women experience symptoms, most do. And many people frequently report that their cycles become erratic, whereas some women say my periods are every 2 weeks, they're very heavy, I have clots, I miss 1 period, I miss 6 periods. So it's very different for everyone. Very common symptoms are also like menopause, hot flashes, night sweats, irritability, not sleeping. A lot of women say, I never had PMS symptoms, but I have them now. A lot of women with anxiety and depression all of a sudden, or a lot of women who have been on an anti-anxiety or an antidepressive medication, all of a sudden it's not working for them anymore and they feel like they need a higher dose. And then the typical, everyone reports weight gain, or maybe they don't gain weight, but their body just changes. Now they have a belly. They never had a belly before. And we hear joint pains, fatigue, headaches. A lot of women report headaches. They never had headaches. Now they do. And a lot of women also report palpitations, and they're going to their cardiologist because they think they have a heart problem, and they don't. Decreased libido is also very common. But what I think is very important for women to also understand about perimenopause is there are many, many women who have perimenopausal symptoms and their periods are still completely regular. So they don't associate their symptoms with perimenopause, and neither do most of their doctors.
If we talk about menopause, not just the symptoms, obviously. Dr. Kinney, I want to talk about the long-term implications of menopause, because I think it's important, and I think we're starting to move into that conversation so people realize we're not saying, okay, I've got a few symptoms, but they're tolerable symptoms, so maybe I don't need to talk about hormone therapy, right? But there are long-term implications of some of those symptoms and of menopause in general. Can you discuss that?
Certainly. So we know from data from young women who had to have their ovaries out because of cancer or pathology of their reproductive organs, that if we don't give those women estrogen, they are much more at risk to develop cognitive problems and heart problems, and obviously bone problems. And so younger women who are in their 40s that are starting to have symptoms that their estrogen is running out, so perimenopause, you need to bring that up to your doctor, because that has long-term health consequences. So if we get those patients started on hormone therapy early, for the rest of their life, their brain, their heart, and their bones benefit. And again, this isn't just my opinion or Dr. Haver's opinion or Dr. Noble's opinion. We have well-designed multiple trials that document this. And just let's take, for instance, about bone health. In the United States, as many women die every year of a hip fracture as die of breast cancer. So, if you don't start on hormones and replace your estrogen when you're younger, you're going to be at tremendous risk for a hip fracture. 30% of women will experience a fracture at some point in their life. And in this country, 1 out of 4 of those women will never leave a nursing home. Same thing, brain health. What is the cure rate for breast cancer now? It's well over 90, 95%. What's the cure rate for Alzheimer's disease? Exactly, zero. So again, by getting on estrogen early, that can be brain protective. And then lastly, the cardiovascular disease. Just last month, Matthew Nudi and his colleagues at University of Pennsylvania published an article based on the WHI. They went back and looked at the data again. What did that show? That women who were on hormones had decreased cholesterol, decreased LDL, your bad cholesterol, increased HDL, your protective cholesterol, and decreased insulin resistance, which means you're less likely to have belly fat. And lastly, estrogen decreases your lipoprotein A, and there is no statin, no exercise, no supplement, no diet that's going to do that. So again, long term, we now know that women who start their hormone therapy early get a lot of protection. Lastly, women who start their hormones early have a 3 to 4 year benefit as far as longevity compared with women your same age who don't start hormone therapy.
You know, I've heard this question 3 times in the last 2 days, and I know we're going to talk about it in the next panel in depth, so your questions can be answered. But when we talk about how long you can stay on hormone therapy, I had somebody raise their hand yesterday and said, like, how quick can I get off of it? How long? Yes, take the mic back. Sorry.
You can stay on hormone therapy until they put you in the grave. I mean, thank you. We should not be subject to age discrimination. We shouldn't. Men stay on testosterone until their 80s. So women can have hormone therapy as long as you want. Now, every year after age 60, I would encourage you just to have a conversation with your doctor. Make sure your risk hasn't changed. If you got a blood clot after your hip replacement, or you've developed high blood pressure, it doesn't mean you have to stop your hormones, but you need to have a conversation about that with your doctor every year. Why? Because age is a risk factor. And as long as you're under 60 and pretty healthy, you can take all the hormones any way you want: pills, patch, ring, spray, gel. But over 60, I would just advise discussing it every year with your doctor. And as long as your risks are still low to moderate, that's your decision to continue.
Thank you. All right, so we talk about sign and symptoms, but Dr. Soviero, I want to talk about how the symptoms differ according to race, ethnicity, and socioeconomic status. Can you go into that and drill down into the SWAN study as well?
Yeah, so there was a study done. It was called the SWAN study. And what it really studied was the menopause transition in women. And this was a study that actually had 5 different ethnic groups in it. It had whites, it had African Americans, it had Hispanics, Asians, and Japanese. And we learned a lot of things from the SWAN study, but we learned that women who start having vasomotor symptoms after menopause, so after their last period, had symptoms on average for about 7.4 years. But women who started having their vasomotor symptoms, so hot flashes and night sweats, in the perimenopausal period, actually had worse symptoms and longer symptoms, and their symptoms can last on average for 12 years. We also learned from SWAN that women who have moderate to severe hot flashes or persistent hot flashes actually have an increased risk of heart disease in the future. Then we also learned that different ethnic and racial backgrounds experience the menopausal transition differently. So we found that Black and Hispanic women actually enter perimenopause much earlier than other women. So for many of these women, they're actually in their 30s when their perimenopausal symptoms start. We also found that Black women and Native American women actually have worse vasomotor symptoms, more persistent, more severe. And on average for Black women, their symptoms can last for 10 years. That's a really long time. Hispanics were not that far behind them, and their symptoms lasted on average for about 8.9 years, where white women had symptoms for about 6.5 years. Japanese and Chinese women actually had the least severe symptoms, and they lasted on average for about 5 years. So we really need to take this information into consideration when you have someone sitting in your office. Every conversation you have is different based on that person, based on their background. And the other thing we learned from SWAN is that women from from lower socioeconomic status, despite their ethnic or racial background, they also had more severe symptoms and they also went into menopause earlier.
We also know there is a strong heart study. Can we talk about that?
Yeah, that was the one where we got the data about the American Indian women. That wasn't part of SWAN. I just stuck that data in there. But yes, and that they're also at higher risk for heart disease.
You know, when we talk about this and we talk about needing research dollars and funding, what do we need next in terms of understanding how different all of us go through menopause? Because it really, I mean, we're talking about so many years, we're talking about so many symptoms, so many different variables. What is that going to take in terms of a larger study?
Well, I think what's very important is that we realize perimenopausal and menopausal care is very individualized. And I think it's really more, we really just have to get the education out there. So for example, we commonly get women that come in and say, oh, I have hot flashes. I'm just going to wait it out. It's just going to pass. And it's our job to say, well, for you, your symptoms on average can last 10 years. Do you really just want to blow it off or wait, as opposed to maybe your friend who their symptoms may only last 6.4 years. So for me right now, I feel like our biggest thing is we need to educate not just patients, but we really need to get out there and educate gynecologists. Most of us were not trained. We weren't trained to do this. We weren't trained about hormones. I was trained in the time where we didn't even talk about it because it was after the WHI. So we didn't even learn about it. So I think we really have to educate people and the differences, woman to woman, even if you're within the same racial ethnic group, it's still going to be different woman to woman. So it's really just educating everybody.
Yeah, and I just want to say this, if you are going to a doctor or dealing with a doctor who says, listen, your symptoms just aren't that bad, or, you can get through this time, or they're not really willing to have that conversation, then you do have to find another doctor. And that's why I get so excited when all of these doctors and physicians are here and stepping up and talking about it and saying, look, it was not something that was taught. They have taught themselves, they've researched, they've studied, they've spent hours and years really understanding all this and putting it together and talking about it one-on-one in an office. And so it really is it's a privilege to have them here on the stage. So
it's also
thank
kind
you.
of frustrating because I was talking to Mary Claire yesterday and we were saying how since we weren't trained for this, I
Sure.
think back to the times where I blew patients off. They would come into me and say they had joint pains and I would say, oh, it's not related to your cycles and I look back now because I didn't know. And I wish I could remember all those specific patients that I gave misinformation to. And I wish I could go back and to apologize to all of them because we weren't trained.
Well, you don't have to apologize because you're here now and you're changing
Yeah.
so many, many lives. So thank you for that. Uh, So Dr. Noble, I was wondering, can you walk us through the available non-hormonal treatment options? Because we do know that there are some women, the numbers are very low in terms of the number of women that are taking hormones or maybe want to or cannot. So can we talk about some of those changes that are available?
Sure. And I just wanted to piggyback on what Dr. Soviero said. We also need to educate all of the doctors in other specialties because those patients that present to cardiologists or dermatologists or their internists, our job, really everybody in this room, is to spread this knowledge because too many people don't get access to the information, and we really have to continue advocating for ourselves. The other thing about treatment options is people need to understand there isn't one right way to play this. There isn't one right answer. Everybody's journey is really different, and people should be empowered to do what they feel comfortable doing. So for some people, they might want to do hormone therapy. They might want to do a lot of other things. Other people might want to do kind of natural options, double down on exercise, lifestyle behaviors. So what I tell my patients is there's so many treatment options available. It's about what you want. It's about your philosophy. It's about the severity. Again, with some caveats that if they're very early with this onset, we really should treat, but there are not a lot of shoulds. This is about what that person wants. And I think we need to be empowered to do what we feel comfortable with. And then I'm a big believer in trials. It can make sense to try something. If symptoms are worse, then we need to go on to the next thing. But the goal is to make things more palatable to help us lead our healthier lives for the next decades. So non-pharmacological treatments, we want to double down on lifestyle changes, healthier eating habits, avoiding ultra-processed food, sleep hygiene, limiting alcohol, recreational substances, movement, and exercise. And this is about what fits for your lifestyle. So things like yoga and acupuncture, if someone wants to pursue that. Now, here's another, comment about some of our data. We don't have all the answers, which is clear. So if the Menopause Society finds there's no benefit of acupuncture, that might not, bear to be true over the years. So I think we have to have a healthy sense of humility that we don't have all the answers. Try what feels right to you. Let's try to avoid anything that's harmful. Avoid getting taken advantage of. There's not great data on any of these supplements. So I think let the buyer beware. If you feel that probiotic really helps you, then I tell my patients, go ahead and do that. But some of these things can be harmful, and people are making an awful lot of money off some of these things. Cognitive behavioral therapy can be helpful. Hypnosis has been shown to be helpful. Couples therapy. When we talk about libido is so multifactorial. So I tell a lot of my patients, couples yoga has been shown to be as effective as testosterone therapy. It's so multifactorial. It has to do with our mindset, our relationships, other stressors in our lives. So I think one of the critical things in educating women is that this transition is actually about understanding that our health really changes, and it's an accelerator of cardiovascular disease. So we need to double down on these healthy lifestyle habits, but there are also some non-hormonal options, pharmacologic treatments, mentioned like the medications that we use for mood, like SSRIs, SNRIs, gabapentin. So for people that either can't do hormone therapy because they're a breast cancer survivor, and we're even moving the needle on that. So I think some of the rules that we thought were true just they're not true. So there's a lot more room than I think people understand, but people can try some of these medications. There's even a stellate ganglion blockade, which is when they put a needle and block a nerve. So there are things that can fit with what, your lifestyle, your philosophy. Birth control pills can be incredibly helpful in the perimenopause, because with these roller coasters, I often tell patients that I think managing the symptoms of perimenopause is actually more challenging than managing menopause, because we're kind of a flat line in menopause. That's easy. Perimenopause, if someone either doesn't tolerate birth control pills, can't do birth control pills, say they're a smoker with high blood pressure, that can get a little trickier. There's some newer medications that really affect the thermoregulatory center in the brain. Really interesting research on fezolinetant. But again, it's not going to protect our hearts. It's not going to protect our bones. So it's about finding out what seems appropriate to you, getting the information. Trials are really helpful. And there are a whole host of things that we can do.
I know that a lot of people have told me, and I was one of them, I went into my doctor initially and was given Lexapro. So I know antidepressants are, one of these oftentimes prescribed as a first line of defense of something, because we don't really, not all women know they're in perimenopause or menopause. Can we talk about that though? Because I know that's one of the non-hormonal up there.
And I think what's so important is I don't think people should just be, given this and told you like, try this first. I think discussing all the options is what's really helpful, because for some of those mood medications, they can be a bit helpful with hot flashes. They can be helpful with the increase in anxiety and mood symptoms, irritability, but that isn't the whole picture. So I think, giving people kind of the cafeteria style of like, this is what's going on. These are the whys, why you're experiencing this. And I find that even just empowering people to understand what's happening, it can help them kind of process, when am I having my symptoms? What's most important to me? What are my goals? And what might I choose? And then kind of go through that line, rather than this prescriptive of like, this is the only thing you can start now. This is the only thing I would offer you. If you start getting those narrow answers, you need better care. We deserve better care.
So you have somebody that comes in and says, I want to do it naturally. What is that answer?
So
Lifestyle changes?
Yeah, I think naturally it's got to be what your philosophy is. If you have, good genetics ahead of you, you know how your family ages, you're very comfortable. I truly feel right now there's not a right answer. We don't have evidence that says everybody at the normal age of menopause should do hormones. I think they can do hormones. I think we can do a lot of things. But I think if you want to kind of age naturally, that's when we double down on the exercise, the healthy eating, the sunblock, strength training, bone health. So there isn't something that I think should be really prescriptive. I think it's about what fits for your lifestyle, with these exceptions that early menopause should be treated, and breast cancer screening, preventative cancer screening, aging naturally and well, and empowering ourselves to do that is okay too. And some people don't want to do hormones. That's okay too. It's about you being you.
Real quick, I want to go into alcohol because that's been a big conversation of late, and I think that we should address it. I know I had I had a glass of wine 2 nights ago, and I woke up in the middle of the night and I went, "Oh, I knew it! I thought like I had fallen asleep. I was so happy. I'm like, I'm going to defy all those studies." But it really
Yeah.
does change during this time. Could you explain
Yeah,
why?
I mean, we definitely metabolize things differently as we age. That's not a surprise to people. It impacts our sleep, it impacts our bone health. We know it's not good for us, but I also think that people need to be empowered to, do what fits in their lifestyle. If they want a glass of wine with friends, I'm not going to tell them they can't do that. But, the overindulging on things, whether that's food or sugar or inflammatory things, we're getting more and more research about how important our diet is and that gut health and how it informs satiety and our metabolism. Alcohol, all of these things are interrelated with bone health and cardiovascular disease. Do you have anything else to add on that, either of you?
You can jump in. Jump in.
Yeah.
I was going to say, I always tell women too, and I'm not saying I don't drink wine, but women who drink one glass of wine a day actually puts them at increased risk for breast cancer, 1 in 1,000 risk, which we quote is the same risk of going on combination hormone therapy. So when you put into perspective, drinking one glass of wine every day, same risk. And if you drink 2 glasses of wine every day, that increases your risk of breast cancer even more than going on hormone therapy.
It's really about choices, right? And what fits for what we're willing to do.
And I just want to take the opportunity to let everybody know that we finally know what causes hot flashes. For decades and decades and decades, we had no earthly idea. We do now. And we have one drug on the market that targets that part of our brain that specifically knocks out the hot flashes. And here's the nice thing. Our sleep center and our mood center are very close to that. So these drugs, and there's another one coming out this summer, these drugs are non-hormonal, they're oral, they don't have a lot of side effects. And if hot flashes and sleep are your big quality of life issues, you may want to ask your doctor about this new category of drugs that are very effective.
But unfortunately, let's talk about drugs and drug prices. These medications aren't cheap, and we need to advocate for better coverage for all these options. So sometimes we deserve these options, and some of the easier hormonal options are just not covered well. So I think those of us that practice taking care of all women, we've got to be real about what people can afford, what is realistic, and what their insurance will cover.
Let's talk about that. We have women that are working hard to advocate for themselves because that's where we are right now, and that's what we have to do. It can be hard to access a menopause informed provider. It just can. I know that the Menopause Society has a patient portal on the website, but let's talk about and Dr. Kinney, I'll start with you on this. Let's go there first about finding a provider, and then I want to go into preparing for a first appointment.
So the Menopause Society, which I will say has a strong advocacy for clinician education. So we've got lots of doctors here who educate consumers. And we do have a lot of consumer information on the Menopause Society's website, but it's menopause.org. And you go there, there's a tab that says find a healthcare provider. You click on that, put your zip code in, and it will give you the list of providers in your area who are members of the Menopause Society, and even more particularly have gone through extra training to obtain the Menopause Society certified practitioner degree. So again, that's one easy way. It allows you to pick somebody in 10 miles, 20 miles, 50-mile radius. The other way is there are wonderful doctors. Dr. Haber, for instance, on her website has a list that you can find doctors in your area that she knows are qualified and good. There are other, like Let's Talk Menopause. They have a place on their website where you can find a provider in your area.
First appointment, again, I always feel like the onus is on the woman to go in there and be prepared. And we know that the appointments don't last very long because the doctors are doing as much as they can to move through and get as many people in as possible. How would you best recommend women prepare for that first appointment?
So first of all, this is the cardinal rule. Don't show up for your annual well woman visit and bring up menopause. You're not going to get it covered. The doctor is already trying to get your breast exam, your pelvic exam, your vulvar exam, your pap smear, go over other health history. So make a separate appointment for this. That way you'll know, the doctor will be prepared and you will be prepared. Secondly, write your questions down ahead of time. Pick your 3 or 4 top issues that are really impacting your quality of life, and make sure before you leave, those 4 things are addressed. Then next, you need to come prepared with the history of your menstrual cycle. Have there been changes? Have you stopped? When did you stop? You also need to make a list of all the symptoms you're having and ask the doctor, are there any other symptoms of menopause that I need to be aware of? Joint pain is the #1 reported menopausal symptom of women worldwide. But how many women are aware that this shoulder pain we thought was a rotator cuff is actually just because our estrogen is low? You also want to bring a complete list of your medications, whatever you are on from other doctors, not just hormone therapy. It would be nice if you have tried other things to bring a list of that. You want to make sure you have a complete health and surgical history so that the doctor can quickly look at that and make sure you don't have any personal or family history contraindications to hormone therapy. And then that's when they would talk about some of the other options, both non-hormonal and lifestyle. Can you guys think of other things for the first?
It's so tough. All those points are really helpful, but I think also being realistic, because sometimes we can't fix everything right away. It's a lot of kind of back and forth education. I think people really need to feel heard. So I think some of those first visits, we really need to kind of do the detective work together. And I think one more note on finding that provider. Just because someone's a certified provider doesn't mean it's going to be the right doctor for you. We wish that everybody could really hear people and form those partnerships. But and this is one area of medicine where it's so individualized, and you really have to find someone that's going to partner with you and understand what your goals are, what your preferences are. So I think that first meeting can also be challenging. You've got to see if it's a good fit. You've got to see if you understand each other, if this is somebody that you can work with. And I wish everybody got everything addressed that first time, but sometimes that's not realistic either. Sometimes we need more information. I do a lot of risk scoring with my patients. So I really have them think about, what is their kind of perceived risk of breast cancer, and what's that risk calculation of breast cancer? What's their risk for osteoporosis? What's their family history? What's important to them? Are they terrified of dementia? And, that plays a role in how we counsel people, because there isn't a lot of great data about dementia and some of these various regimens. We have to guide people as best we can. The other one is cardiovascular disease. So I want to see if they have a lipid profile, and if I can calculate their ASCVD risk, that helps. That's the atherosclerotic cardiovascular disease risk, and that can help us understand what is that person's risk, what's that time since that menopausal transition. So going back to those definitions, we don't need to know exactly when that last menstrual period was, but we need to know roughly, was it a year ago? Was it 7 years ago? Because that informs our decision making. So I think, being realistic about the information that you bring, your goals. Sometimes patients come in and they're not sure what they might want to do. I can have visits where someone knows they want hormone therapy, and we're going to end with hormone therapy. Other people might have been really reluctant to do something like that, or it's the first time they've heard about how an IUD could be really helpful for their bleeding. And then sometimes they'll be able to make that decision by the end of the appointment. I might even be able to put that IUD in and start them on hormone therapy. And we might have gone 180 degrees around, or full circle. But I think being open to things you might not have considered can be really helpful, and finding that partnering.
Yeah, I would also say in that appointment at some point, maybe not the first one, but bringing up sex. Dr. Kelly Casperson's in the house. I know we're going to have a good sex talk coming up, but I would say bring that up, because I don't necessarily know that that's something that most doctors ask me. If you're dealing with painful sex or low libido, I would encourage you to be proactive in having that discussion. Telehealth options also, Dr. Cheryl Malone is here, can speak more on that with Alloy. So those are some incredible options to get to women that might not have menopause specific providers in the area. I know we want to take some questions coming up. Are there any final thoughts that you all? Yeah, yes.
I just wanted to add something. So Most women, when you go to your gynecologist and you bring up perimenopause and menopausal symptoms, most of you are going to be dismissed. The gynecologist doesn't really, they don't have the information. They don't want to address it. They don't have the time. So you have to also be able to speak up for yourself. Don't be shy and advocate, because when you do find somebody, don't think that you can't bring it up. My last two doctors ignored me, so therefore it's in my head. Like, speak up for yourself, advocate for yourself, because there are doctors that are going to address it. So it's very important that you know, like she said, not all doctors are going to do it, but advocate for yourself, because you will find people that will listen to you.
Yeah, absolutely.
You know, a couple red flags too. Red flags are if people say, oh, that's all perimenopause, because sometimes some of these symptoms can be something else. It could be a thyroid disorder. So there are times where we need to do the detective work. We need to do the testing. Most of the time, testing's not needed. But if somebody lumps everything and kind of blows it off as perimenopause, that's a red flag.
Yeah.
If somebody dismisses everything and says this is all normal, that's a red flag. So a couple of things like that can be, you know, good indicators to you that maybe you need to find a different provider.
Perfect. Thank you. Yeah. Somebody told me recently that her doctor said to her, listen, perimenopause is just trending right now. Don't worry about that at this point. And I was like, what? If we could get to a place where it was trending. Okay. Okay. One other
thing.
Okay.
The other thing is sometimes people have been on birth control pills for 2 decades, and then they come into my office and they say, I'm having, you know, weight gain, stressors, can't sleep, and they think it's all perimenopause. If they're on that same pill, it's actually not hormonal. So we've got to remember that this happens in a time in our lives when there are a lot of other stressors. Sometimes people have aging parents, teenage kids, empty nesters, financial stressors. So sometimes it's not all hormonal. Sometimes it is all hormonal.
Right.
So I think we need to be open to that too.
Thank you so much. All right. So I know you all have some questions. I hope you got, this is not a shy room, I assume. So we're going to bring the mic around to ask questions. I think we also have some questions online. So if you want to raise your hand and we'll run the mic over. Is that the best way to do it?
Yes.
Yeah.
All right.
Okay.
So the mic works.
So if you want to, yeah, raise your hand, and we also have a QR code there for Q&A if you're
Yes.
watching us virtually.
Okay. I was just really amazed about the conversation around the SWAN study. And I'm just curious if you can give any further insight to, like, what are the factors? Why is ethnicity like impacting the length of time? Because I don't know, it just kind of shook me. And I'm just curious if you can provide any other details around what factors play a role in those.
We don't really fully understand why. Sometimes we think a lot of it is cultural. Everyone looks at their symptoms differently. Certain cultures don't talk about symptoms. Certain cultures normalize their symptoms more than other people. Certain cultures may have more pressing issues going on in their lives or their cultures, where they minimize their symptoms and, okay, it's a horrible hot flash, but I have really other things going on. And again, every nationality is different in terms of how their family talks about it, how their mothers did it. So I think there's a lot of factors. There's also different health risks in different populations, which also plays a role. So we don't fully know, and there's definitely a lot more research that has to be done to understand that fully.
I just want to add that we know social determinants of health and basically socioeconomics, stressors, anxiety, they actually all increase health risks, and they increase that perception. You know, pain can be different, hot flashes can be different, and they're epigenetics. There's now evidence that, you know, the stressful experiences and patterns of abuse or poverty all actually impact our health. And that can be some of the factors where people experience these things, you know, more readily for longer, and sadly they get less access to care. So one of the most important things we understand is different ethnicities, particularly in this country, don't even have as much access to care. So not only do people experience those symptoms longer and more severely, but they're probably getting less care for it. So that's why people in this room, we all need to advocate for better care for all ethnic groups and better access. I don't know if you have anything to add.
Lastly, I just want to add that we do know that there are some racial and ethnic differences in the lining of people's blood vessels and their propensity to get diabetes, and that's a metabolic thing. So there are physiologic things in your body. If you're an American Indian, then you have and a woman, you have a 30% chance of dying of your diabetes. So again, if you're African American, we know you have more risk of high blood pressure or stroke. So those type of physiologic things also impart you to more severe hot flashes, particularly.
I've been reading and hearing and listening to podcasts and the news, and I'm hearing more and more about how GLP-1s are now being introduced into the menopause world and how they are helpful with some of these symptoms and high cholesterol and heart issues, obviously with weight. And I'm just curious now that this is kind of I know I had the conversation with my OBGYN just recently about how a lot of her menopause patients are now taking one to help with some of these symptoms. And I was just curious about your opinion about that.
Yeah, I'm going to pass the mic around so that we can all have an opportunity to talk about this, because I think this is really, we're right on the forefront of how this can, impact our health. We know, though, that weight and obesity actually impacts all of these things. So I think it's not probably GLP-1s by themselves. I think it's getting the weight off. So no matter how we can get that weight off, that's going to actually impact our risk of diabetes, cardiovascular disease. But we're seeing really interesting things with these GLP-1s. By getting the weight off, it actually impacts PCOS, endometriosis, all these other health issues. So I think it's about getting the weight off in the way that fits for you, whether that's medications, whether that's healthy lifestyle. It's incredibly difficult to be successful with just lifestyle changes. So we know even bariatric surgery, they just did a head-to-head comparison on cost between bariatrics and GLP-1s. So I don't think there's a right answer, but I know it's so interrelated in our sleep, our satiety, cardiovascular risk, bone health.
So Danielle Hartoda and her colleagues at Mayo did a study on the GLP-1s, women who did not take estrogen or hormone therapy and women who did. And the drugs are much more effective in women who are on hormone therapy at the time they're getting their GLP-1s. So there is some connection. Well done for you.
Thank you.
I deal with brain health, so I'm super excited that you guys brought in brain health into the conversation. But I have a question for me and a lot of my friends, because we've been on the hormone not the pill, for a while. And literally 3 gynecologists said, oh, we won't know if you're in perimenopause or menopause if you're on a pill. We have no way of finding out. Yes, I have the symptoms. I know I'm in it. But how do we know that this is the time it ended, like the period has ended if you're on the pill? Because there's so many women we're talking and like, I don't know, should I get off the pill now? Should I risk getting pregnant? Like, what do I do?
Yeah, that's a good question. So, if the average age of menopause is 52, there are some OBGYNs that'll allow their patients to be on birth control anywhere from, age 52 to 55. Because we don't know if you're in menopause, you're right. You don't know if you could still get pregnant. So I tell people there's no reason to come off of it unless you have any other medical issues. I tell them to just stay on it, and then we can either come off and transition you into menopausal doses, or some people just want to know. So if someone really just wants to know if they're in menopause, if they stop their pill, then we see if they get their period. I'm not big on checking hormones, but some women, if they come off the pill, we can check what are their hormone levels and maybe say you may be in menopause, but you don't know if you're in menopause until it's a year without period. So even if you don't get a period right away coming off the pill, it doesn't mean you can't conceive. So if someone doesn't want to be on the pill anymore, then we talk about other options of birth control, such as the Mirena IUD or the Kyleena IUD. And then we can always add estrogen if they have symptoms.
Yeah, I would just add too that family history can play a role. So I often tell my patients that we guesstimate, right? We keep you on until probably the normal age. If you have a family history where people tended to be under 50, maybe we can segue you to either hormone therapy if you want that, or take you off around 50. If people have a history where women in their family really cycled into their mid 50s, we know it's probably going to be longer, but you're absolutely right. We guess, we talk it through, we talk about family history and what people want.
Okay. If you're on birth control pills and start to develop symptoms of perimenopause, I take my patients off the pills for 6 weeks, draw a blood test and an FSH. If it is over 50, that is fairly good evidence that you are menopausal. I agree, it doesn't fit the definition where you have to go a whole year without a period. But at that point, I go ahead and discuss options for the treatment of the perimenopausal menopausal symptoms with the patient.
The only issue I have with that is you can have an FSH that's quite high and you could still ovulate. So you could still have an unplanned pregnancy.
Birth control has to be a part of the conversation until you actually are in.
Yeah. Yeah, and the testing can be really confusing. Someone can have an elevated FSH and someone can say they're menopausal when they're actually not. They could ovulate 4 weeks later, or they could have tons of perimenopausal symptoms and they could have a totally normal FSH and people say, oh no, it's totally normal, you're normal. When we know they're not, the next month they could skip cycles for 3 months and have a much elevated FSH. So the testing really has to be, suspect.
I always say, honestly, if you feel good and there's no reason to come off it, why? So why come off of it to see if you get symptoms? I kind of feel like if you feel great and you're doing great, stay on it. Keep feeling great.
I like the keep feeling great.
Yeah, keep it up.
Well, I'll take that. Okay, we have a question from online, and then I see we have 2 hands in the back.
Yeah.
Do you want to start with the online question?
Sure. So there was a question around diet and nutrition and any changes we should be thinking about that in terms of what we eat.
Okay, so changes in diet, nutrition, and what you should be eating during this time, and any changes that should take place.
Oh, I could go on a long time about diet.
All right,
I know.
We got 8 minutes.
There is no one right diet that fits for everybody. That's been clear over decades where we've been given bad information about non-fat diets, all of these other things. We know in certain areas of the world, blue zones, more and more plant-based is really healthy for us. That's probably the best diet in terms of longevity. We should try to get more proteins, but we can still get plant-based proteins, more fiber, avoiding ultra-processed foods. I tell my patients when someone says you need 100 grams of protein, I don't even think that's feasible or possible. I don't think we should be doing we could have differing opinions in the room, but I don't think we need to be doing protein powders and all these other things. I think eat real food, know where it comes from, be able to pronounce it, be able to make it in your kitchen, do what works for you and make it livable.
So there were some interesting studies that women that ate better nutritionally had a prolongation for the onset of menopause. And we know from studies that that has longevity benefits. So I agree with the dietary information.
Okay, we have 2 questions in the back. If you put your hands up high, we'll get you a mic.
I just wanted to go back to the birth control conversation. I am not a doctor, but I am a menopause specialist. And I always ask my clients to talk to their doctors about reconsidering birth control when they're at that menopausal age, because birth control suppresses ovulation. You don't have progesterone unless you ovulate. If you don't have progesterone, you have mood issues, you have sleep issues. There are a lot of things that happen in terms of your regulation and production of cortisol, which really affects women. I heard all 3 of you mention it. Can you address that?
Yeah, I mean, what I'll try to distinguish is when we want to suppress ovarian function in that perimenopausal period where we're having that roller coaster. That's where birth control pills are incredibly helpful, because you're absolutely right. They suppress ovulation, they control those hormone levels, and people can essentially avoid perimenopause. But once that ovarian function ceases in menopause, which again, we've pointed out, we can't always tell exactly when, but once that's happened, we don't need these higher doses to suppress ovarian function. And as we age, higher doses in oral forms have slightly increased risk of clot and stroke. So we can segue someone to kind of a safer option as we age. So I saw a patient recently who was 60, still on her birth control pills. And I was like, okay, that's not a great idea. We can still give you hormones, but we don't need that higher level, right? So it's about risk and risk tolerance. It's about where we age. I still do have some patients in their 60s that are having normal ovulatory cycles. It's rare, but we can see it. So we need the higher doses to suppress ovulatory function, and we need the lower doses when we no longer have to do that. Does that make sense? And we can still use progesterone in hormone therapy regimens, which we'll hear more about, but that dose depends on whether we're competing with ovarian function versus when that's kind of ceased. Sorry? Lots of different types of estrogens and different kind of potencies too. Mhm.
Hi. A lot of time at this stage in our lives, a lot of people have complex medical histories where they're under the care of a lot of different physicians. And what I've found is, sometimes you're on board with the OB-GYN, but you're seeing an endocrinologist for something, or, you're under the care of an oncologist just because you're doing post-cancer care and screening and surveillance. And maybe one physician's on board and one physician's not, or has some questions. So how do you kind of rally the team? Do you recommend, maybe one physician speaking to another, talking about the whole patient, instead of just like segmentals into their specific specialty?
Yeah, it's a really good question, and it's really complicated. It really should be interdisciplinary. The more complicated it gets with oncologists and cardiologists, we really do have to talk, but as we're all aware, it's harder and harder to find that time, find that provider that will really go that extra mile. That's where a primary care provider can be really helpful. But in reality, a lot of the times you're not going to have agreement. And I have a lot of times where a patient comes from an oncologist where they've told her no, and we talk about shared decision-making and the nuances of it. And she might end up wanting to do something where the oncologist said they're not comfortable. So we very often deal with situations where you might not have everybody on board. So we've got to do our best to counsel that person, talk about risk tolerance, talk about what their goals are. And that interdisciplinary discussion is really valuable if we can make it happen. Anything to add?
Hey,
Okay.
I think this might be
Just to add to something that I also use those opportunities when I have a patient come in and my primary took me off the hormones, or my other doctor took me off. As much as I'm like, oh, I don't have the time to call, I use that opportunity to pick up the phone and call the other doctor to discuss it, not just for that patient, but just to give them that little extra education. Because if us as gynecologists don't know, the primary is not going to know, the cardiologist isn't going to know. So I try to use those opportunities to, even if it's just a 5-minute little education in a non-judgmental way, just to help educate them too.
I like that.
And one thing that's incredibly important is I think doctors sometimes don't realize the power in their words.
Yeah.
And sometimes somebody will just kind of hint at something like, I don't know that that's such a good idea. And it's incredibly harmful. And I think, people are told, even if they've had a hysterectomy, you'll hear later that estrogen for the rest of their lives, there are more benefits. And I see every week people being told, you should kind of be off that. Aren't you old enough? And it's incredibly harmful. So I think it's, again, all of our responsibilities to educate the doctors, understand that people don't know everything. We've learned a lot and we've made some mistakes. And for that, I'm really sorry.
Well, I think it's about taking charge of our health, right? And then that's what you all are here educating all of us to do. So that's the best part.
Hi, great conversation. So my name is Shanta Colette, and I have a question for somebody like myself. I've had a stroke, a heart attack, I have ASCVD, and I have the LPA biomarker, and I cannot do HRT. Are there any non-hormonal clinical strategies that actually have been proven for someone like me to use?
Well, it depends on what your symptoms are specifically, because if you're having the vasomotor symptoms, so the hot flashes and the night sweats, there are a bunch of options that we already mentioned. If your issues are mood, irritability and stuff, then we would try, maybe one of the SSRI, SNRI. So it really depends on your symptoms. It's every. Yeah, that's really tough. So then you would have to really probably more focus on lifestyle changes for your heart health, for your bone health. So yeah, you're pretty tough. We'd have to have a panel discussion about you.
And don't forget the vaginal health. We'll hear it's very easy. Nobody should be suffering from vaginal dryness, pain with sex, urinary urgency. There's a decreased risk in urinary tract infection by about 50%. And there's no timing criteria there. You can be in your 70s and start vaginal estrogen. So we'll hear more about that, but nobody should be suffering from that. Please tell your friends, your mothers, your aunts, sisters. Exactly. So don't put up with that.
Yeah.
Yes.
Vaginal estrogen.
Yes.
All right. We're going to wrap on that note, because we're going right into hormone therapy. We're going to wrap up this panel. Thank you for being so generous with your time. I'm so appreciative.